Hello all, my name is Dr. Vivek, Senior Resident in Department of General Medicine. So I'll be discussing some of the few important drugs which are important for your examination. So we can discuss in the following headings: classification, pharmacokinetics, mechanism of action, pharmacological actions, adverse effects, uses and contraindications, and special situations. So first we can discuss about metformin. As you all know, metformin is an anti-diabetic agent. It's a biguanide. So the mechanism of action of metformin includes three major mechanisms. First mechanism, if it decreases the hepatic glucose production, it decreases the intestinal absorption of glucose, and it improves the insulin sensitivity by increasing peripheral glucose uptake and utilization. Okay, some of the important pharmacokinetics points includes onset of action usually within days, and maximum effects are seen up to 2 weeks. Okay, protein binding is negligible. Half-life elimination in plasma is 4 to 9 hours, and in blood 17 hours. Okay, excretion mainly through urine, 90% as unchanged drug. Okay. Indications in the treatment of type 2 diabetes mellitus. Others includes antipsychotic induced weight gain, treatment of gestational diabetes mellitus, ovarian hyperstimulation syndrome, prevention in patients with PCOS undergoing in vitro fertilization. So the major adverse effects includes majority are seen with gastrointestinal, diarrhea, nausea, flatulence, dyspepsia, vomiting and abdominal pain, lactic acidosis, and vitamin B12 deficiency. So the contraindications are hypersensitivity to metformin or any component of the formulation, severe renal dysfunction, acute or chronic metabolic acidosis with or without coma, cardiovascular collapse, and disease states associated with hypoxemia, including cardiorespiratory insufficiency, which are often associated with hyperlactacidemia. Stress conditions such as severe infections, trauma, surgery, and post-operative recovery phase, usually we won't use metformin in these settings, and in severe dehydration. So in pregnancy, agents other than metformin are currently recommended to treat diabetes mellitus. Metformin may be considered for the treatment of gestational diabetes mellitus in patients who cannot safely or effectively use insulin, example either due to cost, comprehension, or cultural issues. Metformin should not be used in patients with hypertension, preeclampsia, or those at risk for intrauterine growth restriction due to risk of fetal growth restriction or acidosis in the setting of a placental restriction. So as far as breastfeeding is concerned, metformin is usually present in breast milk. So the decision to breastfeed during therapy should consider the risk of infant exposure, the benefits of breastfeeding to the infant, and the benefits of treatment to the mother. So this is metformin. So next we can discuss about atenolol. So atenolol, as you all know, it's a beta blocker. It's a beta 1 selective agent. Mechanism of action: it competitively blocks response to beta adrenergic stimulation, selectively blocks beta 1 receptors with little or no effect on beta 2 receptors, only except at high doses. Pharmacokinetics: onset of action, usually a beta blocking effect. The onset will be less than 1 hour when consumed orally. The peak effect will be seen at when consumed orally 2 to 4 hours. The duration of action with a patient with a normal renal function, the beta blocking effect will be around 12 to 24 hours. Okay, the antihypertensive effect of atenolol when consumed orally will be around 24 hours. Absorption: it is orally when consumed orally, it is rapidly absorbed and it is incompletely absorbed. Okay, distribution: because of its low lipophilicity, it does not crosses the blood-brain barrier. Excretion: 50% of the drug is excreted through feces, and 40% as unchanged drug in the urine. So the adverse effects includes bradyarrhythmias. In most cases, AV blocks associated with a beta blocker will resolve upon discontinuation of the agent. Bronchospasm: usually selective beta blockers, example atenolol, have a lower risk of bronchospasm compared to non-cardioselective beta blockers. Usually atenolol have been associated with least incidence of asthma attacks. Okay, CNS effects may cause reversible CNS effects such as fatigue, insomnia, vivid dreams, memory impairment, and sexual disorder. Usually hydrophilic beta blockers such as atenolol penetrate the blood-brain barrier to a lesser extent than lipophilic beta blockers, possibly leading to a lower incidence of CNS effects. Another important adverse effect regarding the usage of beta blocker or atenolol is the potentiation of masking of hypoglycemia, and finally withdrawal symptoms. Okay, contraindications for the use of beta blockers or atenolol is one is hypersensitivity to atenolol or any component of the formulation, sinus bradycardia, AV blocks greater than first degree, cardiogenic shock, and uncompensated cardiac failure. So some of the uses of atenolol includes long-term management of patients with angina pectoris, management of hypertension, Usually, beta blockers are not recommended as the first line therapy as in JNC guidelines. Okay, in the early treatment and secondary prevention of myocardial infarction, we can use beta blockers or atenolol. Okay, so the other uses of beta blockers includes for the maintenance of ventricular rate control in atrial fibrillation or flutter, prevention of migraine, supraventricular tachycardia, thyrotoxicosis, and in symptomatic ventricular premature beats or ventricular arrhythmia patients. Okay. So as far as pregnancy is considered, atenolol crosses the placenta and is found in the cord blood. So the maternal use of atenolol may cause harm to the fetus. Okay, adverse events such as bradycardia, hypoglycemia, and reduced birth weight have been observed following in utero exposure to the atenolol. So breastfeeding, when breastfeeding is considered, atenolol is present in the breast milk. Okay, bradycardia have been observed in some breastfeeding infants and neonates, and it may also be at risk of hypoglycemia. Okay, so adverse events may be more likely in premature infants or infants with impaired renal function. Okay, so usually use of a beta blocker other than atenolol may be preferred during breastfeeding. Okay, so you can see this is atenolol. Okay. So next we can discuss about enalapril. Enalapril, as you all know, it's an angiotensin converting enzyme inhibitor. Okay, so the mechanism of action is it competitively inhibits the angiotensin converting enzyme, thereby preventing the conversion of angiotensin 1 to angiotensin 2. Okay, as you all aware that angiotensin 2 is a potent vasoconstrictor. So by inhibiting the angiotensin converting enzyme, the and conversion of angiotensin 1 to angiotensin 2 does not happen. Okay, so it results in the lower levels of angiotensin 2, which causes increase in the plasma renin activity and reduction in aldosterone secretion as well. Okay, so pharmacokinetics, the onset of action usually when consumed orally, the peak effect will be seen at around 4 to 6 hours. Okay, so the duration of action will be around 12 to 24 hours. Absorption, so usually 55 to 75% of the drug is absorbed. Okay, so the metabolism, it's a prodrug actually. It undergoes hepatic biotransformation to enalapril. Okay, excretion, the drug is excreted via urine and the feces. So coming to uses, ACE inhibitors are used in the management of hypertension and also in managing patients with heart failure with reduced ejection fraction. So the other indications are in the management of non-ST elevation acute coronary syndrome and in post-transplant erythrocytosis. Okay, so the adverse effects, the most common adverse effects following the use of ACE inhibitors are acute kidney injury. There may be azotemia, increased blood urea nitrogen levels, and increased serum creatinine levels. It's usually seen in all ages. Okay, angioedema, there will be a dry hacking cough, usually non-productive cough due to the accumulation of bradykinin, and there hyperkalemia is also seen. Okay. Contraindications for the use of ACE inhibitors includes hypersensitivity to enalapril, angioedema related to previous treatment with an ACE inhibitor, idiopathic or hereditary angioedema, concomitant use of an ACE inhibitor with aliskiren in patients with diabetes mellitus, or co-administration with or within 36 hours of switching to or from a neprilysin inhibitor, example sacubitril. Okay, so in pregnancy, enalapril usually crosses the placenta. The active metabolite enalapril can be detected in the newborn. So exposure to an ACE inhibitor during the first trimester of pregnancy may be associated with an increased risk of fetal malformations. Okay, so in breastfeeding, enalapril and enalapril both are present in breast milk. Available guidelines consider enalapril to be acceptable for use in breastfeeding. Okay, so it's a tablet of 2.5 milligram of enalapril maleate. Okay, so coming to glibenclamide. As you are aware, it's an anti-diabetic agent classified under sulfonylurea. It's also known as these group of drugs are also known as insulin secretagogues. Okay, mechanism of action includes stimulates insulin release from the pancreatic beta cells, reduces the glucose output from the liver, and insulin sensitivity is increased at the peripheral target sites also. Okay. So coming to pharmacokinetics, the onset of action usually when a drug is taken orally, the serum insulin levels begins to rise 15 to 60 minutes after a single dose. Okay, usually 1 hour after a single dose. The duration of action will last for about 20 less than 24 hours usually. It has an extensive protein binding. Okay, primarily to albumin. It forms metabolites and it is metabolized in the liver. Okay, the excretion is happens via feces and through the urine as metabolites. Okay. So uses, as you all know, it's used in the treatment of type 2 diabetes mellitus. So these groups of drugs are administered with meals, okay, at the same time each day. So adverse effects includes gastrointestinal side effects such as epigastric fullness, heartburn, nausea, hypersensitivity reactions, disulfiram-like reaction. The most common and frequent side effect is hypoglycemia, okay, and cholestatic jaundice is also seen. So contraindications, one is hypersensitivity, type 1 diabetes mellitus or diabetic ketoacidosis with or without coma, and stress conditions as stated already, severe infections, trauma, surgery. Okay. So as far as pregnancy is considered, glyburide usually crosses the placenta. Okay. So severe hypoglycemic episodes lasting 4 to 10 days have been noted in infants born to mother taking a sulfonylurea at the time of delivery. Okay. So agents other than glyburide are currently recommended to treat diabetes mellitus in pregnancy. So breastfeeding, glyburide may be present in breast milk. Okay. So due to the potential for hypoglycemia in the breastfeeding infant, a decision should be taken whether to discontinue breastfeeding or to discontinue the drug, taking into account the importance of treatment to the mother. Okay. So this is a T.Daonil, as you all can see. It's a Glibenclamide. It's a 5 milligram tablet. Okay. So next we can discuss about Atorvastatin. So it is an antilipemic agent, HMG-CoA reductase inhibitor. Okay. So the mechanism of action routes, it's a inhibitor of 3-hydroxy 3-methyl glutaryl coenzyme A reductase, the rate limiting enzyme in the cholesterol synthesis. Okay. This then results in a compensatory increase in the expression of LDL receptors on the hepatocyte membranes and a stimulation of LDL catabolism results. So these group of drugs also possess pleiotropic properties, including improved endothelial function, reduced inflammation at the site of the coronary plaque, inhibition of the platelet aggregation, and also has anticoagulant effects. Okay. So pharmacokinetics, the onset of action, the initial changes will be seen in 3 to 5 days, and the maximum reduction in the plasma cholesterol and triglyceride levels are seen within 2 to 4 weeks of the intake of drug. Okay. So the absorption, it is from oral routes rapidly absorbed. It undergoes extensive first pass metabolism in GI mucosa and the liver. Okay. So the metabolism is by hepatic via CYP3A4 enzyme, and the drug is excreted via bile. Uses, the studies are used in the management of heterozygous and homozygous familial hypercholesterolemia. So coming to adverse effects, there will be increased serum transaminases and hepatotoxicity. Usually the increase in ALT is typically greater than increase in AST. Okay, so there will be muscle related effects, myalgia, myopathy, rhabdomyolysis, immune mediated necrotizing myopathies are usually seen. Okay, so the gastrointestinal side effects are also commonly seen: dyspepsia, nausea, diarrhea, and in some patients there will be insomnia also. Contraindications for the use: one is hypersensitivity to atorvastatin, acute liver failure, or decompensated cirrhosis. Pregnancy considerations: because there is a potential for fetal harm, statins should be discontinued once pregnancy is recognized. Okay, based on the limited data available, when a statin is needed in a pregnant patient, a more hydrophilic option such as rosuvastatin, pravastatin may be preferred. Lipophilic statins such as atorvastatin, simvastatin may be more likely to cross the placenta and increase the risk of congenital malformations. Okay, so as far as breastfeeding is concerned, it's not known if atorvastatin is present in the breast milk. Available guidelines suggest resuming statin therapy once the breastfeeding is complete. Okay, here you can see the atorvastatin 20 milligram tablets. Okay, coming to aspirin, it is an analgesic, non-opioid, NSAID, and an antiplatelet agent. Mechanism of action of aspirin includes it irreversibly inhibits COX-1 and COX-2 enzymes by acetylation, which results in decreased formation of prostaglandin precursors. Okay, it irreversibly inhibits formation of prostaglandin derivative thromboxane 2 by acetylation of platelet, thus inhibiting the platelet aggregation function also. Pharmacokinetics, the immediate release preparation of a non-entry coated tablet, the platelet inhibition action will be less than 1 hour. Entry coated tablets will take around 3 to 4 hours for the action. Okay, so the duration of action, the immediate release preparation, the duration will be around 4 to 6 hours. However, the platelet inhibitory effects last the lifetime of the platelet. Okay, due to its irreversible inhibition of platelet COX-1. Okay, absorption, immediate release preparations are rapidly absorbed in stomach and upper intestine. Extended release capsules, the rate of absorption is dependent upon food, alcohol, and gastric pH. Metabolism is primarily by hepatic conjugation, and the drug is excreted via the urine. Uses, it's used as an analgesic, antipyretic, and an anti-inflammatory agent for revascularization procedures. Vascular indications such as ischemic stroke, TIA, acute coronary syndrome, secondary prevention after acute coronary syndromes, and in the management of stable ischemic heart disease. Okay, so some of the adverse effects includes mild to severe dyspeptic symptoms, peptic ulcer disease, gastrointestinal hemorrhage, hypersensitivity reactions may be immediate and delayed, DIC, hemorrhage, prolonged bleeding time, and prolonged prothrombin time. Contraindications includes hypersensitivity to NSAIDs, and you should use these agents caution in patients with platelet and bleeding disorders. Okay, so coming to pregnancy considerations, adverse effects are reported in the fetus following maternal use of high dose of aspirin, including mortality, intrauterine growth restriction, salicylate intoxication, bleeding abnormalities, and neonatal acidosis. Okay, so except when used in lower doses for pregnancy related conditions, the maternal use of aspirin should be avoided. Okay, beginning 20 weeks of gestation. Breastfeeding considerations. Occasional dose of aspirin to be compatible with breastfeeding, but recommends avoiding long-term therapy and consider monitoring the infants for adverse effects. Here you can see aspirin 75 milligram gastro-resistant tablet and is enteric coated. Okay. Next is azithromycin. Azithromycin is a macrolide antibiotic. Mechanism of action includes it inhibits RNA-dependent protein synthesis. Okay, at chain elongation step, it usually binds to the 50S ribosomal subunit, resulting in the blockage of the transpeptidation. Pharmacokinetics, usually the absorption is rapidly from the GI tract when consumed orally. Distribution, it is extensively tissue distributed, distributes well into the skin, lungs, sputum, tonsils, and cervix. Penetration in the CSF is poor, however. Okay, metabolism, hepatic metabolism, usually it is metabolized to inactive metabolites, and excretion is major route of excretion is biliary. So the uses, it's used in Shanghai, COPD, acute exacerbation and prevention, Mycobacterium avium complex, otitis media, acute otitis media, pelvic inflammatory disease, in the treatment of community acquired pneumonia, skin and soft tissue infection, the treatment of group A streptococcal pharyngitis, urethritis and cervicitis. Okay. So other uses includes babesiosis, the management of dromomanosis, Lyme's disease, lymphogranuloma venereum, and empirical treatment of traveler's diarrhea. Okay. So adverse reactions includes altered cardiac conduction, including prolonged QT interval in non-ECG and polymorphic VT, clostridial difficile infection, drug-induced liver injury, including cholestatic hepatitis, hepatocellular hepatitis. Okay, delayed hypersensitivity reactions, which ranges from a maculopapular skin rashes and fixed drug eruptions to severe cutaneous adverse reactions. Okay, so the immediate hypersensitivity reaction includes angioedema, urticaria, and anaphylaxis. And ototoxicity may also be seen, which includes hearing loss and tinnitus. Okay. So the contraindications are hypersensitivity reactions to azithromycin or any other macrolide antibiotics. Okay, so you need to use these agents in caution, particularly in patients with a prolonged QT interval. Okay, here you can see the azithromycin 250 milligram tablets. Okay. Next, we can discuss about levofloxacin. So it is, as you all know, it's a fluoroquinolone. It's a respiratory fluoroquinolone. Okay. Mechanism of action: it inhibits the DNA gyrase in susceptible organisms, thereby promoting the breakage of DNA strands. Okay. DNA gyrase, topoisomerase 2 enzyme, is an essential bacterial enzyme. Okay, that maintains the superhelical structure of DNA and is required for DNA replication and transcription, DNA repair, recombination, and transposition. Okay, pharmacokinetics, it is rapidly and completely absorbed when taken orally. Distribution, widely distributed into the body, including blister fluid, skin tissue, macrophages, prostate and lung tissues. CSF concentration is 50% of the serum concentration. Okay, it is minimally metabolized in the liver. Excretion is mainly through urine. Okay, these are some of the uses of levofloxacin. It is used in the treatment of community acquired pneumonia, nosocomial pneumonia, COPD acute exacerbation, acute bacterial rhinosinusitis, UTI, acute pyelonephritis, prostatitis, skin and soft tissue infections, prophylaxis and treatment of plague due to Yersinia pestis, salmonella, usually non-typhoidal infection, Shigella infection, surgical site incisional infection, tuberculosis. Okay, so coming to the adverse effects, arthropathy or arthralgia can be seen. CNS effects may range from dizziness and restlessness to a toxic psychosis. Neuroexcitation may include seizure in some patients. Okay, and clostridial difficile infections are also seen. There will be usually this glycemia. Hepatotoxicity will be seen. Both the cholestatic and the hepatocellular patterns are seen. Hypersensitivity reactions, immediate and delayed, both can be seen. Okay, an exacerbation of underlying myasthenia gravis is seen. Peripheral neuropathy, phototoxicity or skin photosensitivity, prolonged QT interval is also seen in the ECG. Tendinopathy and tendon rupture can also be seen. Okay, so coming to the spectrum of activity of levofloxacin, Generally, fluoroquinolones are broad-spectrum antibiotics with potent activity against aerobic, enteric, gram-negative bacilli, and many common respiratory pathogens. Levofloxacin has greater activity against gram-positive organisms mainly, and other respiratory pathogens also. Okay, and the mycobacteria, it is used as a second-line agent in the setting of resistance and or intolerance to the first-line agents. Other organisms which where levofloxacin are effective is Bacillus anthracis, Francisella tularensis, and typhoid. Okay. Contraindications, hypersensitivity to levofloxacin and any other component of the formulation or other fluoroquinolones. Okay, pregnancy consideration, levofloxacin usually crosses the placenta and can be detected in the amniotic fluid and cord blood. Based on the available data and increased in a risk of major birth events, miscarriages, or other adverse fetal and maternal outcomes have not been observed. Okay, following levofloxacin use during pregnancy. Breastfeeding consideration: levofloxacin is present in breast milk. Usually, breastfeeding is not recommended in breastfeeding patients during therapy or for 2 days after the last levofloxacin dose due to concerns of potential serious adverse reactions, but may be considered for use in breastfeeding patients requiring treatment for inhalational anthracis, usually post-exposure. Okay. And here you can see the levofloxacin tablets. Okay, coming to chloroquine. Chloroquine is an aminoquinoline derivative and it's an anti-malarial agent, as you all know. Mechanism of action: it binds to and inhibits DNA and RNA polymerase. It inhibits metabolism and hemoglobin utilization by parasites. It inhibits the prostaglandin effects. Chloroquine usually concentrates within the parasite acid vesicles and raises the internal pH, resulting in inhibition of parasite. Pharmacokinetics: absorption: usually it is rapid and almost complete when taken orally. Distribution: widely in body tissues including eyes, heart, kidneys, liver, leukocytes, and lungs where retention is prolonged. Metabolism: partially hepatic to main metabolite dicetyl chloroquine. Excretion: it's mainly through urine. Okay. Uses, as you all know, in the treatment of malaria, treatment of uncomplicated malaria due to susceptible strains of Plasmodium vivax, malaria, ovale, and falciparum. Okay. It's used in the management of extra-intestinal amoebiasis and discoid lupus erythematosus. Adverse effects includes cardiomyopathy, insomnia, neuromyopathy, ototoxicity is seen, retinopathy, usually blue-black pigmentation and edema, myopathy, peripheral neuropathy with long-term use, intolerance usually manifested as nausea, vomiting, skin rashes, and photosensitivity. Contraindications for the use of chloroquine includes myopathy, visual disturbances, hypersensitivity reactions, and porphyria. Pregnancy considerations: chloroquine and its metabolites usually crosses the placenta and can be detected in the cord blood and urine of the newborn infant. Chloroquine has not been found to increase the risk of adverse fetal events when used in recommended dose for malarial prophylaxis. So chloroquine may be used in all trimesters of pregnancy. Breastfeeding considerations: available guidelines consider the amount of chloroquine exposure to the breastfeeding infant to be acceptable, okay, when used in normal maternal doses for malarial prophylaxis or treatment. So here you can see the chloroquine phosphate tablets up to 50 milligram. Okay. The next drug is quinine. Its classification is an anti-malarial agent. Mechanism of action: it depresses the oxygen uptake and the carbohydrate metabolism. It intercalates into DNA, disrupting the parasite's replication and transcription. Okay. Pharmacokinetics: absorption: it readily gets absorbed from the upper small intestine. Distribution: intraerythrocytic levels are 30 to 50% of the plasma concentration. Distributes poorly into the CSF. Metabolism: mainly via hepatic through CYP450 enzyme, primarily CYP3A4. Okay, excreted via the urine. Uses in the treatment of uncomplicated chloroquine resistant Plasmodium falciparum malaria in combination with other malarial agents. Okay, and also in the treatment of babesiosis. Contraindications for the use of quinine includes hypersensitivity to quinine or any other component of the formulation, prolonged QT interval, myasthenia gravis, optic neuritis. Okay. Pregnancy consideration: quinine usually crosses the placenta. Based on the available data, the therapeutic dose used for malaria are not associated with an increase in risk of adverse fetal events. Okay. Breastfeeding consideration: quinine considered to be compatible with breastfeeding. Infants should be monitored for hemolysis and jaundice, especially if they are premature or less than 1 month of age. Okay. Here you can see the quinine sulfate tablets. Okay. So coming to theophylline, theophylline is a phosphodiesterase enzyme inhibitor. It is a non-selective phosphodiesterase enzyme inhibitor. Mechanism of action: it has two distinct actions. One is smooth muscle relaxation, and the other is suppression of the response of the airways to stimuli. Okay, bronchodilation is mediated by inhibition of two isoenzymes, phosphodiesterase 3 and to a lesser extent phosphodiesterase 4. Theophylline also increases the force of contraction of diaphragmatic muscles through enhancement of the calcium uptake through the adenosine-mediated channels. Okay. Pharmacokinetics: absorption is usually rapid and complete. Distribution: it distributes whole into the body fat. Volume of distribution may increase in premature neonates, uncorrected acidemia, hepatic cirrhosis. Okay. Metabolism usually via hepatic route through demethylation and hydroxylation. The drug is excreted via the urine. Uses, as you all know, in reversible airflow obstruction. Okay. Some of the important adverse effects includes cardiac flutter, tachycardia, headache, insomnia, restlessness, seizure. Hypercalcemia may be seen in with concomitant hyperthyroid disease, gastroesophageal reflux aggravation, and tremors. Contraindications: hypersensitivity to theophylline or any other component of the formulation. Pregnancy consideration: theophylline crosses the placenta. Maternal use of theophylline is not associated with an increased risk of fetal malformations. Okay, theophylline is considered compatible for use during the pregnancy. Breastfeeding considerations: maternal use of theophylline is considered compatible with breastfeeding. Okay. So here you can see the difference. It's a combination of both theophylline and theophylline tablets. Okay. Next, we can discuss about mannitol. Mannitol is an osmotic diuretic. Mechanism of action: it produces an osmotic diuresis by increasing the osmotic pressure of glomerular filtrate, which in turn inhibits the tubular reabsorption of water and electrolytes and increases the urinary output. Okay, mannitol usually reduces the intracranial pressure by reducing the blood viscosity, which transiently increases cerebral blood flow and oxygen transport and constriction of the pyle arterioles. Okay, this in turn reduces the cerebral blood volume and ICP, intracranial pressure. So some of the important uses of mannitol: it's used in the reduction of increased intracranial pressure associated with cerebral edema or brain mass, reduction of increased intraocular pressure, genitourinary irrigation solution, irrigation and transurethral prostatic resection, intraoperative volume optimization also. Okay, some of the adverse effects include cardiac failure, localized phlebitis, edema, confusion, dizziness, dehydration, fluid and electrolyte disturbances, azotemia, osmotic nephrosis, polyuria, and pulmonary congestion is also seen. Okay. Then contraindications: hypersensitivity to mannitol, anuria, and in severe hypovolemia. Okay. Next, we can discuss about Seroflo inhaler. Usually, the contents in it is fluticasone, propionate, and salmeterol. Fluticasone is an inherent corticosteroid. Salmeterol is a beta-2 adrenergic agonist. So usually, it's a long-acting beta-2 adrenergic agonist. Okay. So the uses and indications of Seroflo inhaler are maintenance or control in bronchial asthmatic patients, chronic obstructive pulmonary disease. Okay. Adverse reactions includes headache, tachycardia, palpitation, voice disorder, oral candidiasis, musculoskeletal pain, throat irritation. Okay. Contraindications are hypersensitivity to fluticasone and salmeterol and status asthmaticus. So this is the Seroflo inhaler, as you can see. Okay. So next we can discuss about a normal saline, 0.9%. It is a crystalloid. It contains sodium 154 millimoles per liter and chloride of 154 millimoles per liter. So the total osmolarity is 308 milliosmoles per liter. So it is isoosmolar when compared to the normal plasma. Okay. So what are the situations in which you can use this normal saline? One is hyponatremia, the management of hypovolemic shock, septic shock, DKA, hyperosmolar hyperglycemic state, the management of hypercalcemia, whereas vigorous fluid resuscitation is needed. Okay. Intracranial hypertension, parenteral nutrition, and wound irrigation. Okay. Then so next is 5% dextrose. Dextrose 5% in water crystalloid solution. So usually it's in the bag, it is isotonic, but physiologically it is hypotonic with the osmolarity of around 260 milliosmoles. Okay, it raises total fluid volume. It's helpful actually in rehydrating and excretory purposes. In each 100 ml of 5% dextrose injection, it contains dextrose height as 5 gram in water for injection. It usually provides 170 to 200 calories per 1000 cc for energy. Physiologically hypotonic, so the dextrose is metabolized quickly, so that only water remains. Okay, it's also used as a maintenance fluid in the management of hypoglycemia also. That's all about the discussion, and all the best for your upcoming examinations. Okay, thank you.